Welcome to this video on the pathophysiology of diabetes mellitus. Diabetes is a chronic metabolic disorder characterized by persistent hyperglycemia. It results from abnormalities in insulin secretion, insulin action, or both, leading to disturbances in carbohydrate, fat, and protein metabolism. Our learning objectives are to define diabetes, know normal blood glucose values, explain the mechanisms of diabetes pathophysiology, correlate pathophysiology with signs and symptoms, and identify pharmacological targets for treatment. Normal glucose regulation is maintained by a balance between insulin and glucagon. Insulin, secreted by the pancreas, lowers blood glucose by promoting uptake into tissues like skeletal muscle and adipose tissue. Glucagon, from the pancreas, raises blood glucose by signaling the liver. The physiological role of insulin is to maintain glucose homeostasis. It achieves this by increasing glucose uptake in muscle and fat, promoting glycogen formation in the liver, and decreasing hepatic glucose production and systemic lipolysis. Diagnostic thresholds for fasting plasma glucose are normal, 70 to 99 milligrams per deciliter, pre-diabetes, 100 to 125 milligrams per deciliter, and diabetes mellitus, 126 milligrams per deciliter or higher. Other diagnostic values include a random glucose of 200 milligrams per deciliter or higher with symptoms, or an HbA1c of 6.5% or higher. The major types of diabetes mellitus include type 1, which is due to absolute insulin deficiency from autoimmune beta cell destruction. Type 2 involves insulin resistance and progressive insulin deficiency. Gestational diabetes occurs during pregnancy, and secondary diabetes is due to other causes like drugs or diseases. The pathophysiology of type 1 diabetes begins with a genetic predisposition and an autoimmune reaction leading to beta cell destruction. This causes absolute insulin deficiency and resulting hyperglycemia. A complication is increased lipolysis, leading to ketogenesis and a high risk of diabetic ketoacidosis. The pathophysiology of type 2 diabetes is based on two main mechanisms: insulin resistance, where body tissues do not respond properly to insulin, and beta cell dysfunction, where the pancreas cannot produce sufficient insulin. The result is relative insulin deficiency and chronic hyperglycemia. Root causes of type 2 diabetes include the role of obesity, specifically adipose tissue, which releases free fatty acids and inflammatory adipokines, impairing insulin signaling. Additionally, skeletal muscle decreases glucose uptake, and the liver produces excess glucose. Incretin hormones, like GLP-1 and GIP, secreted by the gut, normally increase insulin secretion after meals. In type 2 diabetes, there is a reduced incretin effect, resulting in reduced post-meal insulin secretion. A clinical translation of diabetes symptoms are the 3 Ps. Hyperglycemia leads to osmotic effects, causing polyuria or excessive urination, polydipsia or excessive thirst, and polyphagia or excessive hunger. Other symptoms include fatigue, weight loss, and blurred vision. The mechanism of polyuria starts with hyperglycemia. When glucose exceeds the renal threshold, it appears in the urine as glycosuria. This leads to osmotic diuresis, which results in excess urination or polyuria. Chronic hyperglycemia causes tissue damage through several pathways: the formation of advanced glycation end products, activation of the polyol pathway, and oxidative stress. This results in direct damage to blood vessels and nerves. Complications of diabetes are categorized into microvascular and macrovascular. Microvascular complications include diabetic retinopathy affecting the eyes, nephropathy affecting the kidneys, and neuropathy affecting the nerves. Macrovascular complications include coronary artery disease, stroke, and peripheral arterial disease. Understanding pathophysiology helps identify drug targets. Insulin deficiency is treated with insulin therapy. Insulin resistance is targeted by drugs like metformin and TZDs. Reduced incretin effect can be addressed with GLP-1 agonists and DPP-4 inhibitors.